Okay, did everybody have a good break? If you were taking a diuretic, you probably had to run into the bathroom, but hopefully you took it early this morning. Anyway, with regards to diuretics, they are one of the first-line medications that a lot of people will prescribe. One of the things I have also seen over the numerous years is that they call it cyclic edema. And what does that mean? Well, edema is the term for swelling in your lower extremities mainly, but it can be anywhere there is water underneath your skin. So it's more commonly found in the legs below the knee. Women sometimes will experience edema with regards to hormonal variations in salt and fluid intake. And they will come to a physician and they will say, you know, I've been swelling. Every time I get around my menstrual cycle, I swell. So can you give me a water pill so I can prevent that? Well, okay, this is very dangerous. Cyclic edema means you take a diuretic for a couple of days and your kidneys work very hard to get rid of that salt and water. Then what happens is they kind of go through a resting phase. So imagine that you've been whipping your kidneys for 3 days and all of a sudden the whip is taken away. They take a little break, and so they hold on to salt and water. So here you are, you squeeze it out of your body for 3 days, and then all of a sudden it comes back and you're back on the diuretic. So the cycle goes over and over and over again. So if you're going to take a water pill as any medication, you take it in the lowest possible dose you can. Take it in the morning and take it all the time. Those people that are on low salt diets do very well as long as they maintain a salt diet that's low. If you happen to splurge and go out to a restaurant and you're not reading your labels, and let's suppose you pick up a bottle of V8 juice or something along that and you look at the salt content in it, you might be surprised. With regards to that salt takes 3 days to get out of your system. So hence, you know, it would have gone away anyway had you done nothing. So if you're going to take that salt in and you're going to swell, it will go out on its own. You do not need to hasten or quicken its exit. It will take care of itself. Unless you have really bad kidneys and you're in end-stage renal disease, then in that case you will have difficulties with regard to salt retention and you might go into congestive heart failure. And I did mention that on a previous show. Your kidneys do not have eyes to the outside world. They were meant to hold up your blood pressure during periods of dehydration. So if the blood flow to the kidneys is reduced, therefore they think you're dehydrated. So they secrete hormones that cause you, or hormones that basically are chemicals to maintain and enhance salt retention and fluid retention. And this is one of those mechanisms that kind of goes awry, meaning it's a feedback loop that can work negatively, and we see it a lot. And as you build up fluid, if you've had some heart disease, your heart will stretch, and if it stretches past the point of maximal contraction. There's something with regards to heart called Starling's law. Starling's law says if I have a muscle fiber and I pull it to its maximum fiber length and I contract, I'm going to get a maximal contraction. When I pull it past that, I get no contraction. This is where congestive heart failure comes in there. The heart is damaged, it's full of fluid, and you're stretching the heart muscle too much and it doesn't pump. Well, what happens when that starts to happen? Well, again, the kidneys see a decrease in blood flow, so they hold on to more salt and water. So it's a feedback loop that was meant to protect us when we were foraging, and now that we're living older and having more diseases that we normally would have died of other causes, now we're succumbed to congestive heart failure. So that being said, it's real important that if you're taking a diuretic that you take it all the time, because the minute you stop taking it, you're going to retain salt and water. If you're a congestive heart failure patient, that could send you into congestive heart failure. So please don't run out of that particular product. So we have a slide, and I think if they can bring that back up, I want to talk a little bit about that. So this is the and if you look at down there, there's Lasix, which is, again, I said once of the day diuretic. Bumex is a little bit stronger than Lasix and does last most of the day. Hydrochlorothiazide indeed lasts most of the day, and metallazone is an add-on, a very strong diuretic, and will be used when Lasix is failing, or an add-on to Lasix. And again, spironolactone is used with Lasix a lot to cause potassium potassium retention. One of the things I want to tell you is that if you're using any ACE inhibitor or AR2 blocker or angiotensin receptor blocker, and you're using spironolactone and Lasix, be very, very careful, because spironolactone plus the AR2 blockers cause potassium retention. So it's very important that you maintain, even though you could be taking a diuretic that can cause potassium loss, those medications can cause you to retain potassium. And if you don't know this, if your potassium level gets too high, it will cause your heart to stop beating. So it's very important that you do check your potassium levels if you're on those particular products. Okay, so we're going to go to the next slide, which talks about calcium channel blockers. And it's a very complex group of medications. One of the groups are the dihydropyridine group, and this were one of the first calcium channel blockers that came out on the market, nifedipine, and its second generation products like Norvasc. They do directly vasodilate the arteries. They can treat angina, and as a matter of fact, one of the things they used to do in the ER a long time ago was basically give someone, if they were having, instead of giving them nitroglycerin, they would give them sub-Q nifedipine. Well, if you look at underneath treating angina, you'll see reflex tachycardia. And where they went against that was because if you dilate your blood vessels, again, you reduce, your heart rate picks up. It's almost like your blood pressure is dropping, and your baroreceptors, we talked about those, they kick in, and that maintains your blood pressure. So that's not what you want to do in someone that's having a heart attack. You don't want to make their heart work harder. So as you know, they don't do that anymore. They give nifedipine underneath the tongue. And in a rare case, I won't bring it back up just yet, but in certain patients, dilating the blood vessels in a patients with nephropathy can get increased proteinuria. And that's what nephropathy is, a leaky filter. And if you leak enough protein out of your kidneys, proteins are what keep our fluid in our tissues. It's called oncotic pressure. And if we are malnourished, or if we leak protein through our kidneys, we will start to lose fluid into our tissues and edema. So there are other causes of edema other than congestive heart failure. If you have leaky kidneys, you will also do that. And that's called third spacing. It's a term we use in medicine where the fluid has moved into a third space other than the extracellular tissues, and it's kind of maintained there. Very hard to get it out of there, and we try and give diuretics, but at the same time, the risk is that you can't get the fluid out of the tissues, and you basically diurese somebody even more, and you lower their blood pressure even further. So it isn't always as simple as it seems. Oh, I got a little edema, let me take a diuretic. No, you have to understand why you have the edema so that the treatment fits the disease and the mechanism, or what we call the pathophysiology of that disease. Okay, next group of calcium channel blockers was basically this is another group called diltiazem, or the benzothioprine. This is a particular very middle-of-the-road beta calcium channel blocker. It basically has an intermediate class between what we call short DHP, which is dihydropyridine, and the non-dihydropyridine group. It's very useful. It has both a cardiac depressant and a vasodilatory actions, and I like it because I can use it in the COPD patient, the chronic lung patient who may need blood pressure control, but I don't want to give some of the vasodilators. I don't want to increase tachycardia. I want to try and control heart rate. So I'm trying to find that middle between those particular issues. And, when we start talking about beta blockers, which is one of the next medications we'll talk about in the COPD patient, it's very important that we have another medication that we can help slow that heart rate or the work of the heart. It can be one of those nice tools to find a mix so you don't interfere with a person's ability to breathe. Then we're going to talk about the non-dihydropyridine groups. There's 3 calcium channel blockers, and the one you've probably heard a lot about is verapamil. Verapamil is a drug that actually is given to actually slow the heart rate down, but it basically can dilate blood vessels also. It's very useful it has less reflex tachycardia, and it probably is also very semi-useful in COPD patients, and can slow the heart rate. We give that to people with SVT, supraventricular tachycardia, to try and slow their heart rate down, and it also can be used in coronary vasospasm. So the dihydropyridine group, which we talked about, the nifedipines and the norvascs, they cause a lot of peripheral edema, especially at higher doses in that 10 milligram use. And when you combine it with an ACE inhibitor, they tend to reduce that. So we use a lot of combinations. There isn't one medication that is better for one group as a normal, but in general with regards to high blood pressure, and I don't say that doesn't mean that if you are white, and then you will probably respond better to a ACE inhibitor and renin system. If you are darker color, you will probably respond better to a calcium channel blocker and a diuretic. So based on your skin color, I may lead to, and no, I'm not a racist, but you may lead to better medications that are more definitive. These are just what these things have come out over time with medications that are very useful for these particular groups. So there is a little bit of method to the madness, so to say. We probably don't have enough time to talk about beta blockers, which is in the next group. They are a very, very complex group of medications. They've been out for a long time, and they've come full fold. Basically, we'll talk about those on our next show with regards to selective and non-selective beta blockers. But they are very important in heart disease and congestive failure. And not to waste your time and get into anything I can't really talk about tonight, we'll save it for the next show. Anyway, this is Dr. Reiner. I'm signing off tonight. Thank you for tuning in tonight, and hopefully we'll see you here next Monday night. Thank you for tuning in.